Hello, everyone. In this session, we'll discuss carpal tunnel syndrome, one of the most common entrapment neuropathies seen in general practice. We'll understand what it is, why it happens, how to diagnose it, manage it, and when to refer, all explained step by step with practical examples. Carpal tunnel syndrome, or CTS, occurs when the median nerve is compressed at the wrist as it passes through a narrow space called the carpal tunnel. This tunnel is formed by the carpal bones below and the transverse carpal ligament above. Inside it run 9 flexor tendons and the median nerve. Because the tunnel is rigid and cannot expand, any swelling of its contents or reduction in its size increases pressure on the nerve. As a result, the median nerve loses its normal function, leading to tingling, numbness, and eventually weakness of the hand. Now let's understand why this happens. The basic mechanism is raised pressure inside the tunnel, which reduces blood flow to the nerve, causing ischemia and damage. This can be due to repetitive wrist movements, overuse from typing or machinery work, wrist fractures, arthritis, or even hormonal and fluid changes during pregnancy. Systemic conditions like diabetes, hypothyroidism, and rheumatoid arthritis are frequent contributors. Initially, the nerve fibers lose their insulation or myelin, producing intermittent symptoms. If compression continues, there is axonal damage, which may lead to permanent weakness. That's why early detection and treatment are vital. Let's move to clinical presentation. Patients often describe tingling, numbness, or burning in the thumb, index, and middle fingers, sparing the little finger. These sensations are typically worse at night and may wake the patient, prompting them to shake or flick the hand for relief. Pain can radiate up the forearm or even to the shoulder. As the condition progresses, patients may complain of dropping objects or difficulty performing fine tasks like buttoning shirts or writing. Long-standing compression leads to weakness and visible wasting of the thenar muscles at the base of the thumb. Although both hands can be affected, symptoms are often worse on one side. On examination, inspect both hands carefully. Look for thenar muscle wasting, which signals chronic nerve damage. Check sensation in the median nerve distribution. Test thumb abduction and opposition. Weakness here supports the diagnosis. 2 simple bedside tests can be used. In Phelan's test, ask the patient to flex both wrists and press the backs of their hands together. Tingling or numbness within a minute suggests CTS. In Tinel's test, tapping over the carpal tunnel produces electric shock, like sensations along the median nerve territory. While these tests help confirm suspicion, they are not completely reliable. Diagnosis always depends on the clinical picture. When the diagnosis is uncertain or before considering surgery, nerve conduction studies and electromyography can be performed. These detect slowing of electrical signals across the wrist and grade the severity of nerve damage. Additional tests such as thyroid function, blood glucose, or inflammatory markers are useful if systemic causes are suspected. This distinction helps differentiate CTS from similar conditions like cervical radiculopathy, where neck involvement may cause similar hand symptoms. Now let's discuss management. For mild to moderate cases, conservative treatment is usually effective. Start with nighttime wrist splinting in a neutral position. This prevents wrist flexion during sleep and relieves pressure on the nerve, reducing night symptoms. Encourage activity modification. Avoid repetitive forceful hand movements, heavy gripping, or prolonged wrist bending. Workplace ergonomics, such as adjusting keyboard height or using cushion supports, can make a big difference. A local corticosteroid injection into the carpal tunnel can offer short-term but meaningful relief by reducing inflammation and swelling. At the same time, address underlying medical problems such as diabetes or hypothyroidism to prevent recurrence. If symptoms persist beyond a few months, or if there is weakness, muscle wasting, or severe changes on nerve conduction studies, the patient should be referred for surgical decompression. The procedure, called carpal tunnel release, involves dividing the transverse carpal ligament to expand the tunnel and relieve nerve pressure. Most patients experience marked improvement in numbness and pain, though recovery of strength may take time. Early surgery gives the best results before permanent axonal loss sets in. Let's look at 2 short clinical examples. First, a 40-year-old typist complains of nighttime numbness in the thumb and index finger for 3 months. There's no weakness, and examination is normal. This is an early and reversible stage. Night splinting, ergonomic correction, and avoiding repetitive strain are advised. Within weeks, her symptoms settle completely. The second example is a 60-year-old diabetic woman who reports dropping objects and persistent numbness for nearly a year. There's visible thenar wasting and weakness of thumb opposition. Nerve conduction study shows severe compression. She undergoes surgical decompression with significant sensory improvement, though some weakness remains, showing why timely management matters. Always consider differential diagnoses. Cervical radiculopathy can mimic CTS, but often includes neck pain and radiating symptoms. Pronator Terry syndrome causes median nerve compression higher up in the forearm. Diabetic polyneuropathy typically begins in the feet and is symmetrical. Inflammatory arthritis and tenosynovitis can coexist with CTS and worsen its presentation. Evaluating these possibilities ensures accurate treatment. Patients should also receive preventive advice. Encourage proper wrist positioning, taking short breaks during repetitive work, maintaining a healthy body weight, and controlling chronic diseases such as diabetes and thyroid disorders. Pregnant women with temporary symptoms usually improve after delivery, but splints can help during pregnancy. There are a few red flags that require urgent referral: rapidly worsening weakness, visible thenar muscle wasting, or sensory loss extending beyond the hand. Such cases indicate advanced nerve damage or an alternative pathology that needs specialist evaluation. To summarize, carpal tunnel syndrome is a compression of the median nerve at the wrist, most often due to increased pressure within the carpal tunnel. It presents with numbness, tingling, and weakness in the median nerve distribution. Diagnosis is mainly clinical, supported by nerve studies when needed. Early cases respond well to splinting, activity modification, and corticosteroid injection, while persistent or severe cases require surgical decompression. Timely recognition and management lead to excellent outcomes and prevent permanent nerve injury. Thank you for listening.